Thank you, sir. With this, we can ask Dr. Ankita to share the screen and we can start with our case presentation. Dr. Ankita.
Sure.
Good evening, ma'am. Good evening, sir.
Welcome. Welcome. Yeah.
Can you all see my presentation?
Yes,
Yeah,
yes.
full screen mode.
Wait.
Yeah,
Is it full screen, sir?
Not yet.
not yet.
Wait. Is it now?
Yes, yes.
Yeah, you can also switch on your video.
Here. Is it visible now, sir?
Yeah, you are visible now.
Is the screen visible now?
Yeah.
Good evening, sir. Good evening, all. I'd start with my presentation.
Yes, sir.
Hello.
Yeah, please continue. Please continue. Some disturbance.
Yes, sir. Patient Master A, 14-year-old male, resident of Mysuru. He's a high school dropout, and history was given by his mother, and she was reliable. Chief complaints: patient presented with decreased appetite for 1 month, fever with chills and rigors since past 1 week, and breathlessness since past 2 days before the admission. He was referred from outside hospital in view of the RFPs. So I'd start with the background history. Antepartum history. This was a booked case. Mother had received injection tetanus toxide, but she doesn't recollect receiving any prenatal vitamins. Antenatal scan, as per her reporting, which was done at 5 months of gestation, was told to be normal. Birth, this was a full-term normal vaginal delivery, and he was born to a non-consanguineous couple. He cried soon after birth, and he had no history of respiratory distress at birth. Mother says that they was discharged soon after birth. Birth weight was 3 kgs, and there was no history of jaundice, and his feeding was normal at that time, and no history of fever in the initial period. Then at 5 months during his infancy, mother noticed that he started crying every time he had to pass urine. She did not perceive any poor urinary stream at that time. And he had frequent episodes of fever with chills and rigors associated with decreased feeding and vomiting frequently. And he was not gaining weight as per her. And there were 5 to 6 such episodes during that year, in the initial year. For this, she consulted local clinic, and for this he used to receive some syrups for 3 to 4 days, after which his fever used to subside. But again, after some days, he used to have similar symptoms with the crying at the time of micturition. So due to these symptoms and repeated such fever episodes, at 11 months of age, he was taken to the Indira Gandhi Children's Hospital at Bengaluru, where he was told that mother was told that there is obstruction to the flow of his urine and that he would require some surgery. So he underwent surgery through his urinary passage at that admission, and he was discharged after 1 week of admission. And after this surgery, mother says that his symptom of crying at the time of micturition had resolved. But she was told that he had some renal dysfunction. They do not remember the serum creatinine or any other investigation done at that time. And he was advised for regular follow-up, and he was given some oral syrups. However, 1 month after this surgery, his father, who was a manual laborer, he died at accident in workplace, and thereafter they did not follow up ever. So in the initial period of childhood, mother says that his gross motor milestones he had in time. There he was sitting without support by 9 months, and he had started walking 2 to 3 months after the surgery, that is at 1.5 years of age. Other language and social milestones were normal. He was weaned off breast milk by first year of life. He had average scholastic performance at school, And initially he had a normal age appropriate weight gain, and he had achieved continence by the age of 7 by the day, as per mother, but he continued to have bedwetting till 9 years of age, and thereafter he had achieved continence even at night. There is he does not report any voiding difficulty or straining or dribbling of urine in this initial period. At 7 years of age, during cycling, he fell from the bicycle and sustained a left forearm fracture, for which he was taken to local hospital and a cast was put. But he healed with which that mother says that the fracture healed, but it had some residual deformity. But he was able to perform all his activities of daily living. By the age of 8, mother started noticing, and he also started noticing, that he was shorter as compared to his peers in the school, and had difficulty in walking up to the school because he used to have pain in his legs, and gradually developed inward bowing of his legs. And mother also reports that she thought that he's short because he has he did not eat much and he did not have good appetite. And for this they did not seek any initially they did not seek any medical attention. And she said she tried feeding him energy drinks, and then gradually the symptoms progressed by the age of 12 years. And so at 12 years of age, due to this difficulty in walking and bowing of legs, he was again taken to this Indira Gandhi Children's Hospital, where he was found to have renal dysfunction, and he was admitted for 1 week there. He was told that he would require dialysis, and that he was also told that he had a small bladder and the urine was flowing back to the kidney. He was started on some medications, and he was told to continue to follow up for that, but again he was lost to follow up in 2022. Then there onwards, they started noticing that he has again frequent episodes of fever, which were associated with chills and rigors and suprapubic pain, and his appetite continued to deteriorate. And for this he used to take medication from local clinics, some tablets for 4 to 5 days, after which the fever used to subside. There was no history of dysuria, hematuria, graveluria, or pyuria at that time. The leg deformity also continued to worsen. And last year, despite being good at like his scholastic performance, he had to stop going to school because he could not walk to the school because of this pain and bowing of the legs. Now presenting complaints. This time patient presented with history of fever with chills and rigors, and burning associated with burning micturition for 1 week. There was no history of pyuria, foul smelling urine, or flank pain. He did have suprapubic pain and dysuria. There was no history of straining during voiding or incontinence, no history of hematuria or graveluria. He had a history of shortness of breath since 2 days prior to admission, but that was not associated with any history of cough, expectoration, hemopsis, and orthopnea. There was no history of pedal edema. Earlier, his episodes of fever used to respond to the medications which were given at local clinic, but this time mother said that the fever did not subside since 1 week. So he was taken to a local clinic where he was told to have renal dysfunction, and he was referred to Indira Gandhi, and from there he was referred again to INU. Negative history: he had no history of altered sensorium, altered abnormal body movements, no history of any loose stools, constipation, or vomiting, no history of taking any native medication intake, no history of receiving any antiepileptic drugs or steroids, no history of any skin rash, pruritus, or lesions, no history of hair loss, no history of any dental issues, any caries, no history of any vision abnormalities or hearing difficulty, no history of any gum bleed or easy bruisability. So with this, in view of decreased appetite and breathing difficulty, and being told that he was very high, he had very high creatinine, he was initiated on hemodialysis on 27th of December via right eye internal jugular non-tunnel catheter. AVF creation was advised, but he was told that the veins were not found to be suitable, and he underwent 3 episodes of hemodialysis initially. Thereafter, the family did not want to continue on dialysis, so it was discontinued. Foley's catheter was inserted, and he received IV antibiotics as per the culture sensitivity. Urine output was of about 1 to 1.5 liters per day, and he was told to have severe anemia and has been receiving treatment for same. He was treated with antihypertensives, calcitriol, bicarbonate supplementation. Family was explained the need for continuation of RRT, but because they were unwilling for the same. Immunization history: mother recollects that vaccines were given to him in childhood. Whether it is complete or not is not known. The vaccination card was not available. He did not receive any COVID-19 vaccination as per her. He belongs to lower socioeconomic class according to the modified Kuppuswamy scale. Mother had attended middle school, and there is overcrowding where they live. There is no other, he's the only child of a non-consanguineous marriage, and there is no other family history of renal dysfunction or birth defects is known. He consumes a mixed diet, which is predominantly vegetarian. Appetite is poor, and his gross calorie and protein intake was inadequate. So summary, this is a 14-year-old boy with a history of recurrent UTI and dysuria during childhood, and underwent a corrective surgery at 11 months of age. He subsequently had growth retardation in form of short stature and a pathological fracture and deformity. He had recurrent UTIs again from the age of 7 years, and he was treated with the repeated course of antibiotics for the same, did not receive any antibiotic prophylaxis. There's history of renal dysfunction and anorexia and poor drug compliance, and he was lost to follow-up multiple times and has now presented with advanced renal failure and was initiated on hemodialysis. Should I continue, sir?
Yeah, I think you can finish the examination as well.
Yes.
And then you can summarize, or you can, I think you have summarized, I think more than enough. You go ahead with the examination.
Yes, sir. Examination, his temperature was 37 degrees Celsius, blood pressure 120 by 80 millimeters of mercury in left upper limb, which was between 95th to 99 centile, and this was on 2 antihypertensive agents. Pulse rate 98 per minute, regular, normal volume and character, no radial or radiofemoral delay. Respiratory rate was 18 per minute. Saturation was normal. Examination, he was conscious, well oriented to time, place, person, and self. Pallor was present. JVP was normal. Foley's catheter was in situ. Height was 125 centimeter, which is again indicating short stature, as it was severely below the 3rd percentile for the state. For his age. Weight was 24 kgs, again severely below 3rd percentile for his age. Upper segment to lower segment ratio 1.4:1. BMI, which is disproportionate. BMI 15.4, suggesting undernutrition. So he had this chest deformity, and this was the fracture which he had underwent in the left forearm, along with widening of wrist and the deformity. And he had genu valgum with intermalleolar distance being 12 centimeter, and intercondylar distance was absent. There was no frontal bossing, no low set ears or syndromic facies. Oral cavity dentition was normal. Spine was normal. There was no kyphoscoliosis. Skin was, there was no rash or scar marks. Hair was normal. Nails were normal. Eyes, vision normal, no dry eyes. Ear, again normal hearing, no discharges. In systemic examination, respiratory system was normal. There were there were bilateral vesicular breaths heard. No hepatosplenomegaly. External genitalia phallus was normal. Tanner staging 3. CNS, he was conscious, well oriented to time, place, and person. His gait was abnormal due to the bowed legs. There was no sign of tetany. Urine examination, protein was present in traces as such, and it was full of pus cells, and bacteria were also seen on further examination. He had anemia with a hemoglobin of 7.4, and which was normocytic normochromic, and was found to have a creatinine of 5.4, and serum calcium was
No, I think investigations we'll discuss later.
yes, sir.
Yeah. So with this elaborate, well presented, with this elaborate history,
Yes.
and after you have finished the examination as well.
Yes.
So what is your diagnosis?
So diagnosis are probably acute on chronic kidney disease, with acute factor being upper urinary tract infection, and chronic being chronic interstitial nephritis secondary to congenital abnormality of kidney and urinary tract, likely being posterior urethral valve with secondary vesicourethral reflux, and with complications of CKD as per hypertension, anemia, and mineral bone disorder with azotemic rickets.
Okay, so why do you say it is acute on chronic?
Sir, since he had this urinary tract infection at this point in time, and he had presented with the severe metabolic acidosis, which later on recovered, likely that upper urinary tract infection was contributing to acute worsening, but likely he has advanced kidney failure. So
Yeah, it's very difficult to say. Because the disease has been progressing over a period of time, and he has been diagnosed to have CKD well in advance, and
yes,
so
sir.
I agree there can be some acute component, but it's difficult to say it is entirely the acute this thing. Yeah, it is CKD is in CKD stage 5.
Yes.
And yeah, I mean there is a syndromic diagnosis, and the probable pathology is chronic interstitial nephritis. I agree, and then the etiology CACUT. In the CACUT, why do you say it is posterior urethral valve? What are the points in favor?
Sir, he had a history of crying during micturition right in the infancy, and which was later on in the infancy itself corrected with a surgery which was done through the urinary passage, as the mother told. And so, which is why I
So
think.
in general, how does the posterior urethral valve present? When do you suspect a posterior valve?
Sir, it can present even in the antenatal period, in 1/3 of cases, where child can have on antenatal screening, we can see hydroureteronephrosis, and even the posterior urethra would be dilated, which is the keyhole sign, or there can be oligohydramnios or anhydramnios, and this can be found in the antenatal period. Then at birth, there can be child can have difficulty passing urine right at birth, or even during infancy and later. And
can the child present with acute urinary retention?
Yes, sir. Child can present with retention.
Retention. Okay. So when an infant presents with retention of urine, what are the possibilities?
Sir, if it is a male child, then this PUV is one. Then urethral atresia could be another, sir.
And then bladder neck obstruction at the level of the bladder neck.
Yes.
So how do you differentiate between these?
Sir, if we are able to pass the
infant feeding tube, the catheter.
Yes, then it is likely that the urethra is there, and in atresia we will not be able to pass the catheter.
And in most of the patients with posterior urethral valve, you'll be able to pass the catheter. It's the kind of a one-way, like.
Yes.
And what is the current terminology of posterior urethral valve? Still, you would like to use the word PUV, or better terminology is there?
So there is copum.
Yeah, what is copum?
Congenital obstructive posterior urethral membrane.
Why this change in terminology?
Sir, because it is actually not a valve but a membrane.
Not just that. There is a lot of heterogeneity It is not just uniform. It's not just the same. You know the Young's classification, how many types of obstructing membranes or folds or valves have been described?
So 3 types
Yeah.
have been described. Type 1 is most common, which is from
Yeah.
the montanum to the
Fine.
yes, sir, bladder.
Okay. What is this actually? What is the embryologically? What does it represent? This fold which is coming from the caudal end of verumontanum and that is causing obstruction. What does it represent embryologically?
Persisting membranes at the
The remnants of the Wolffian duct. Okay.
Yes.
And the type 2 is a kind of a bicuspid valve and type 3 is different. So the copum is a common terminology that encompasses all these different, the heterogeneous obstruction of the urethra at the level of that. Okay, that's the most important sign, as you've already said, is that, you know, prostatic urethra dilatation, the keyhole sign that can be kind of picked up by a good sonologist. Sound itself, it can reveal. So clinically, as you rightly said, you know, there can be hydramnias and sometimes even fetal ascites has been reported and, you know, hydronephrosis, all that happens. Fine. Okay. I agree with you. It is chronic interstitial nephritis because there is no oliguria, no edema. Is it not? Yeah, all that is fine.
Yes.
But how do you explain hypertension in chronic interstitial nephritis? The blood pressure will not be elevated. But here you said this gentleman, this young boy, is on 2 antihypertensives.
Yes, sir. Sir, likely because patients with PUV have valve bladder, which results in reflux, and the reflux nephropathy per se can present
Exactly.
with hypertension.
That's it. There are 2 chronic interstitial pathologies which can have hypertension as a prominent finding. One is
Vesicoureteric reflux.
reflux. The other one?
Sir, the renovascular hypertension.
No. I said interstitial pathology.
Analgesic.
Already somebody has answered. ADPKD, no?
Yes, sir. ADPKD.
ADPKD is an interstitial disease, but, you know, still you have hypertension. Okay. Why there is hypertension in vesicular reflux?
Sir, one is that the refluxing urine will cause pressure in the peritubular capillaries, leading to the hypoxia and then renin release.
Yes. Not just that, when there is intrarenal infection, pyelonephritis, what happens is that scars formation happens and that results in distortion of the vascular architecture and the downstream nephrons which suffer because of this, and there can be a tremendous ischemic renin drive, you know, that can result. Okay. And then later on, because of scarring and FSGS kind of a pathology can contribute for adaptive FSGS that can contribute for hypertension later on, but at this point of time. So this is very important. Okay, fine. What is the surgery that is being done for copum?
Sir, the fulguration of the valve, sir.
Fulguration, that is exactly the term.
Yes.
Fine. He underwent fulguration at what age?
Sir, at 11 months of age, sir.
11 months of age.
Yes, sir.
So at 11 months of age itself, he has undergone an endoscopic surgery, a cystoscopic surgery. The obstructing membrane has been removed. It's kind of a corrective surgery. And after that, he never had obstructive symptoms. But why all this downhill course?
So one is that intranatally itself, when this back pressure changes, they will cause hypodysplasia of the kidney, sir. Second is that the bladder also undergoes changes to adapt with that increased pressure intranatally and in the initial period of the infancy when it was still not corrected. So due to that, the bladder becomes a high pressure chamber which causes reflux, and which that pathology continues, and therefore the CKD progresses. because of the fibrosis which happens in the bladder and the changes which occur in the kidney, hypodysplasia, which results in concentrating defects and again results in polyuria, which would again make the bladder, which is poorly compliant bladder, reflux, and the high pressure in the bladder again continues. Hello?
Oh, you are fairly all right. But more importantly, like he had several episodes of UTI, high-grade fever with fever and chills.
Yes, sir.
So almost like the upper renal tract that is involving the kidney is quite possible, right?
Yes, sir.
Every episode of acute pyelonephritis during infancy and very early childhood, it has got sinister prognosis. Why?
Sir,
The
because the
prognosis of an
scarring,
acute pyelonephritis in an adult versus an infant, what is the difference? Yeah, because of
scarring which develops, sir, during that time, it would the number
exactly.
of
Yeah, just imagine the infant kidney is such a small kidney. The infant kidney is very small kidney, few centimeters, like 3-4 centimeters. An half a centimeter scar in a 4 centimeter length kidney, the connotation is entirely different. Vis-a-vis the same half a centimeter scar in an adult kidney of 10.5 centimeters. Meaning, even an half a centimeter scar in an infant kidney or a neonatal kidney, that it means that a big chunk of nephrons, they just die off.
Yes.
Is it not? So that is the importance here. The scar that happens in the kidney. So in all probability, there could have been a secondary vesicouretal reflux. And also, it is very well documented and that these cacuts, there can be clustering. In addition to posterior valve, there can be vesicouretal reflux, there can be independent voiding dysfunction, bladder abnormality, and so many other abnormalities also could be there. So, if you were the treating pediatrician, how you would have treated in the early years, and had the parents been very compliant with regular visits and follow-up and so on?
So, sir, one is that at birth itself, if we could identify that he had the PU, then it should have been corrected right after birth, sir.
I agree with that. Beyond that,
So beyond that, since initially itself the renal dysfunction was found, so we should have been very vigilant with the serum bicarb and make sure that he did not develop acidosis in that time. And we should have
now how about prevention of why he developed repeated UTI even after fulguration of the membrane?
valve bladder. So for that, we should have, after the correction of the initial fulguration, sir, 3 months later, we should have kept him under follow-up and followed up with his RFTs if the RFT was in the declining trend and if the ultrasound had persistent HUN or not, and we could have repeated his micturating cystourethrogram to see if there is any reflux. And if the reflux is there, then we should have ensured that there is some diversion to the bladder, decreasing the intrabladder pressures. And yes, sir. And
what is the role of antibiotic prophylaxis as you give it for primary VUR?
Sir, in primary VUR, there is role of antibiotic prophylaxis, but in secondary VUR, the role of antibiotic prophylaxis is not
exactly
proven.
That's it. That's very important. As you rightly said, even after fulguration, if the child suffers repeated these things, first of all, we have to understand the adequacy of the procedure first.
Yes.
Whether it has been done appropriately, the obstruction element was not there. That is number one. And repeated ultrasound examination to look for residual urine in the bladder. And the mother has noticed that the stream was not okay, right? That's what you said.
The mother never found any.
Oh, okay, fine. And then after treating the acute pyelonephritis, then we should have assessed the bladder.
Yes.
If need be, even urodynamic study, because what causes this dysfunction? Because even the continence was not achieved. It was achieved a little later. So there is inherent bladder dysfunction, whether that was contributing for all that. And every episode of urinary tract infection should have been appropriately treated.
Yes.
With this, strictly adhering to the the guidelines of management of acute pyelonephritis. In acute pyelonephritis, the duration of antibiotic therapy is prolonged.
Yes, sir.
Just because the fever subsides, it doesn't mean anything, because there can be micro pockets of inflammation and nidosis for the bacteria within deep into the parenchyma. So the therapy is prolonged, minimum of 14 days and so on. So there is definitely a role for addressing these infections in a very, very substantial way. Number one. Number two, assessment of the bladder function by doing urodynamic study and so on.
Yes.
So once detecting the abnormality in the bladder function, appropriate medical therapy plus or minus surgical therapy could have been attempted.
Yes.
So that's it. So a little bit of digression from the clinical scenario. What will be your approach in a primary vesicular reflux? Quickly, in 2 or 3 sentences, you tell me the management of primary VUR as a pediatrician or a pediatric nephrologist.
The primary VUR during infancy, whatever be the grade of reflux, there is role of prophylactic antibiotics. Then if after 2 to 3 years of age, if the thing is, primary VUR tends to regress with age. As the bladder size improves, the refluxing mechanism regresses. So there is with age it can regress spontaneously. So we can wait for that spontaneous resolution. But if even after 2 to 3 years of age, the grade of VUR is furthering or it is not recovering, then we can and the child is having breakthrough pyelonephritis even after the antibiotic prophylaxis, then there's a role of surgical management for the primary VUR.
Fine. So now there is a lot of controversies, and it's now it has become a contentious issue, like a chronic chemoprophylaxis with a low dose antibiotic for quite some time. Is it really useful?
Yes.
Can you name the trials?
The one was this river trial where they compared antibiotic prophylaxis compared to placebo. So in that they found that even though the rate of UTI decreases, the scarring is the same in both the placebo group and the antibiotic prophylaxis group, and the chance of resistance is more in the patients who were given prophylaxis.
And again, no, but that's a trial. Actually, more than 90% of the children were girls. So there was little caveats were there, but that evoked a lot of controversy and discussion. Is it really worthwhile? So the concern is that the antibiotics on a long-term basis, as you rightly said, it can lead on to emergence of resistant strains. But in this cohort, when they developed a UTI and the bugs were resistant to more than 3-4 microbes, antimicrobials. That is number one. Not just that, giving way for fungal infections, another concern. More importantly, now there is a lot of focus on the gut microbiota, right?
Yes, sir.
So this chronic administration of antimicrobial, it causes perturbations in the gut microbiome. Yes. That can lead on to a lot of problems, including obesity in later life and so on. Yes. So that is the concern. And somebody already has pointed out in the chat box, another important trial, recent trial is PREDICT trial. Have you gone through the PREDICT trial?
No, sir.
Okay. Antibiotic prophylaxis in infants with the grade 3, 4 or 5 VUR and the follow-up at least for 24 months. There is a significant reduction in the incidence of UTI. Actually, these children never had an episode of UTI. So the participants of this trial. So the first symptomatic UTI. So that is an important endpoint. There was a significant decrease in the occurrence of the first symptomatic UTI in the cohort of the children who received. But incidence of new kidney scarring was similar in both the groups. Yes. So again, it is not a it is very categorical, like to suggest that antibiotic prophylaxis is important. But as of now, the guideline mandates antibiotic prophylaxis. that you have to be sure about it. Okay.
Yes.
There are so many trials coming, like PREVENT trial. It's called PREVENT, Prevention of Recurrent UTI in Children with BUR and normal renal tracts. So that is another trial. So in the recent literature, there has been a resurgence of interest on this. The only concern is that, how safe is it giving long-term antibiotics in growing children? The concerns pertaining to the side effects beyond the urinary tract and GI tract and so on. So that's it. So the indications for surgery in BUR.
Sir, despite giving these antibiotics, if there is progression of the grade of the reflux or grade 4 or 5 reflux or bilateral kidney, if there is reflux, then we will consider consider surgical management.
And breakthrough UTI and very gross intrarenal reflux and persistent, grade 5 BUR, that's it. And do you know about the endoscopic surgeries, tissue augmenting interventions by BUR?
Yes, we can give bulking agents at the site of the insertion of the ureter to the bladder, which is deflux, it is called, sir. Dextromer and hyaluronic acid.
Sting procedure and HIT procedure. Please go through the NEJM article on that. It was a decade ago. There was a nice article on that.
Yes.
But again, that's the controversies. The side effect profile, there can be perforation and injury to the bladder, and all this is reported. But the initial article, original article, it showed very good results and not very invasive. It's not open surgery and so on, right?
Yes.
There's nothing but, the submucosal injection of Teflon and other materials. So that's it. And then, of course, open surgery. Fine. Let us move on from here. So I accept with Charcot and chronic interstitial nephritis and so on. You said that the child really had polyuria?
Sir, he did not complain of nocturia as such, but when asked, he would like they denied nocturia, sir. Polyuria also they denied, sir.
Okay.
Yes,
So why there is nocturia? Why there is polyuria in chronic interstitial pathology?
Sir, concentrating defect in the tubules, they are unable to concentrate, and so.
Which is the concentrating segment of nephron?
Sir, loop of Henle and the collecting duct, sir.
Loop of Henle is a diluting segment, no?
Sorry, yes, sir. Collecting duct.
Medullary thick ascending Henle's loop is the diluting segment of nephron, right?
Yes. Yes.
So why is it diluting segment of nephron? Why is it diluting segment of nephron?
Sir, that NKCC channels are there which will reabsorb.
Yeah, there is one potassium to chloride channel.
Yes.
So there's absorption of all these three, but it is impermeable to water.
Yes.
So it is impermeable to water. So the most dilute filtrate is just immediately distal to that. The early distal tubule is the most dilute filtrate.
Yes.
And as you move on, there is action of ABP and concentration happens. So that is the concentration segment. So the interstitium, the tubules and interstitium, they perform three important functions. One is acidification, then dilution, and concentration. Okay, all these things can be kind of perturbed. So that is why you get acidosis out of proportion to the degree of CKD in interstitial pathology. So the previous session I discussed about urinary acidification and so on.
Yes.
Is it not? Right. So that's why there is acidosis and so on. And unfortunately, the acidotic breathing, it is kind of misconstrued as a kind of a breathlessness and volume overload, and sometimes even diuretics being administered by nephrologists, and all that happens. Okay, fine. So then what happened to the child?
Sir, after
He sustained a fracture.
Yes.
So do you think the fracture was due to a real the degree of pressure trauma, or even a lighter injury has resulted in fracture because of the vulnerability for fracture?
Sir, he just fell from his bicycle, and I think it was a pathological fracture, so because of the vulnerability of the bone.
The fragility, because of the fragility fracture.
Yes.
that itself is an indicator of what?
Sir, mineral bone disease.
CKD MBD.
Yes, sir.
So the erstwhile term was ROD. Now we call it as CKD MBD. What is the difference between the two?
Sir, ROD was concerned only mainly with the bone, but now the vascular calcification, soft tissue calcification is also part of the diagnosis, sir.
No, it's a triad,
Right.
the one.
Yes.
So
Right.
ROD is a subset.
Yes,
ROD
sir.
is one component of the broader syndrome of CKD MBD.
Yes, sir.
Oh, ROD is just bone.
Mm,
The
yes.
other two components, as you rightly said, it is the vascular calcification. Then
And
the third component is
calcium, phosphorus,
the
vitamin.
laboratory abnormalities pertaining to CKD MBD.
Yes, sir.
So all these things. So it is more meaningful. It is more clinically relevant. So this particular approach tells you it is not just the problems are not just confined to bones alone.
Yes.
Various aspects of the bone health alone. It extends beyond that. That is why this broad terminology has come in. Okay, fine. So what is the evidence that this child has got CKD MBD?
Sir, one is this pathological fracture that he had, sir.
Okay.
Then second is gradually he had short stature and bowing of legs, sir. That is an evidence, sir. He
Fine.
also yes, sir, developed other bone deformities.
So bowing of legs, we call it as genu.
Sir, both valgum and varum can happen. He had valgum, sir.
Genu valgum. What is the intermalleolar distance and what is the significance of that?
Sir, at his age, actually, he should have achieved the adult level, which is there is no intermalleolar and intercondylar distance, but in him it was 12 centimeters,
Yeah.
indicating that there was
anything more than 8 centimeters is definitely abnormal.
normal. Yes.
Definitely abnormal. Yeah. So this is valgus abnormality. It indicates severity of genu valgum. The
Yes.
more severe the genu valgum, the more will be the intermalleolar distance. Okay. So what are the skeletal examination findings in this child?
Sir, he had this, sir, valgus deformity. Then he had the bowing of the hand, which was secondary to the deformity after the fracture. His wrists were wider than usual, sir, and he had the chest deformity as well, sir. Protrusion of the chest, likely pigeon chest deformity, sir.
So what are the other things you look for? So so this genu valgum and the widening of the distal radii, that is the wrist, they indicate what?
Sir, it is classically found in rickets, sir.
Rickets, fine. So what are the other findings did you look for?
Sir, not in him, but fontanelles may close late, sir, in infants. If
No, but for his age, that is not applicable. Fine.
applicable. Then frontal bossing can be present.
Good. Yes, then?
Sir, then this there can be either pectus excavatum or pectus carinatum.
Good. Then?
Then this valgus or varus deformity.
Okay. Then? Rachitic rosary.
Rickety rosary, yes, sir.
And Harrison sulcus.
Yes.
Where do you look for this rachitic rosary?
Sir, lateral part of the ribs, sir.
At the costocordinal junction of the lower ribs.
Yes, sir.
What do they represent actually? The rosary means actually a bead, right? The rosary, the mala, the bead. It looks like a bony beads.
Yes, sir.
Due to rickets, that's why it's called a rachitic rosary. It is the costocondral junction. What is that enlarged knob-like structure over there?
Sir, it is the metaphysis.
Excessive osteoid, unmineralized osteoid. All these features are, there's a mineralization defect, osteomalacia kind of a thing, right?
Yes.
Rickets is the early form and we call it as osteomalacia because osteoid is more.
Yes, sir.
That's why you get the widening of the distal radii and so on.
So chondrocytes, they have abnormal apoptosis, sir, in
Yes.
rickets, sir. So
Yes.
yes.
And increased osteoid also will be there.
Yes.
And kyphoscoliosis?
Yes, sir, he did not have kyphoscoliosis.
Oh, fine. And does it have this bony abnormalities will have an impact on the proximal muscle strength?
Yes, sir. It will have the proximal muscle strength would decrease, sir. As
how was that in this child?
Sir, he was able to. Sir, power was 4/5, sir.
So that is very important. You have to, without forgetting, that has to be examined in any patient with CKD MBD, proximal muscle weakness as well.
Yes.
Okay, fine. And you said what is the height of the child?
Sir, it was only 125 centimeters, sir. He was
So
less than the third centile for his age, sir.
less than third. So definitely there is a growth stunting, growth retardation. That also was one of the components of your diagnosis that you mentioned nicely.
Yes.
So can you just tell me as to why there is growth retardation in a child with CKD?
Sir, it is multifactorial. One is the nutrition per se, sir. Uremia per se would decrease appetite and the nutrition would be poor. Second is sir, vitamin D deficiency because of the CKD per se, sir. Third is the metabolic acidosis, which is a very important component. The acidosis will cause more bone resorption and it will affect the linear growth. It's because of the increased catabolism and the bone growth will be compromised. So, third, and there is also growth hormone resistance to the insulin, like growth factor 1 and the growth hormone action, sir. And there is anemia, sir. Anemia would also cause.
Can contribute. So these are the primary things. One is the hyperparathyroidism and the CKD MBD phenomena, the acidosis. More importantly, the resistance to the action of the growth hormone. So growth hormone deficit is not there. Most of the these patients with CKD, they can have normal growth hormone level, but there's a resistance at the receptor level. Why?
Sir, because of the uremia, sir, and I think FGF also.
The mediator, what is the mediator of growth hormones action?
Insulin like growth factor 1.
There is a somatomedin that is at fault, you know.
Yes, sir.
So in CKD, that comes down. Okay, fine. And what happens to puberty, onset of puberty in CKD, whether that can contribute for the short stature?
Sir, almost by 2 years it is delayed in the CKD4.
So pubertal delay is an important complication of CKD in children. So puberty, onset of puberty is a kind of a trigger for the linear growth, right? Height. So that also is another factor. Why there is a pubertal delay in CKD?
Sir, the LHFSH, sir, that axis, and also because of growth hormones, sir, resistance.
Resistance, and then GnRH is reduced. More importantly, LH luteinizing hormone, the level doesn't go up. Okay, so it corresponds with that. So that's not happening.
Yes.
So
he has not attained puberty, so he's 14, almost going 15, sir. He has not.
Fine.
Yes, sir.
Fine. So that's it. So in the management, we'll discuss the management of growth retardation, or now itself will finish. So is he a candidate for any specific therapy apart from all these factors?
Sir, growth hormone we can give recombinant.
Why I'm asking this question is that now more and more centers have facility for recombinant human growth hormone therapy, including Madras Medical College in the Department of Endocrinology, and it is covered under insurance as well. So it is not just that, it is not accessible. It was in the past, it was not accessible, but now we know how to handle it and how to select a candidate for growth hormone therapy. So what are the indications for recombinant human growth hormone therapy for addressing the growth retardation in CKD?
Sir, even after correcting all the other factors like nutrition, vitamin D, the calcium.
No, that is the prerequisites.
Yes, sir.
So the height is less than 3rd percentile as in this patient. And one more thing, anything else?
So growth velocity less than
25th percentile. At least over 6 months of time you have to address. So these are the primarily. And before that, all the prerequisites, as you rightly said, acidosis, you should try to achieve by COB 22 and correction of anemia. Ensure the balanced diet and adequate amount of calories and protein, all these things are provided. And then hyperparathyroidism is addressed. And the CKD MBD parameters, the hypocalcemia is corrected and hyperphosphatemia is corrected, and attempts to bring down elevated growth hormone to acceptable levels. All this has to happen. Then what are other prerequisites before venturing into therapy?
Sir,
You have to find out whether there is growth potential in the patient.
yes, sir. That fusion of the epiphysis has not occurred. That
Yeah,
has.
that is very important.
Yes.
So how do you do that? The
Sir,
growth potential has to be ensured before you start growth hormone therapy. What is that?
radiologically we can see, sir, if there is any fusion of epiphysis has not happened.
What X-ray is recommended?
Sir, at the level of wrist joint and at the
Yeah,
level.
left wrist to ensure epiphysis is open. That is important. Anything else you do in examination, clinical examination before venturing with growth hormone therapy?
Sir, I can't think of. Sir.
A fundoscopy. Fundus examination is important. Why? To rule out any pre-existing papilledema due to other causes. Why? Because growth hormone is one of the side effects is
Cerebral edema.
papilledema. So you should not miss due to some other thing like idiopathic increased intracranial tension. Papilledema was pre-existing, and later on, if you pick it up and attributing that for growth hormone. Okay, fine. So how do you administer growth hormone?
Sir, subcutaneously.
Yeah.
It is given.
Do you know the dose of it? What is the recommended dose?
I don't remember.
Fine, you can refer it. No, it's not an issue. Like 0.045 to 0.05 milligram per kg per day, the subcutaneous injection. So we never used to discuss growth hormone administration in greater detail in the past, but now things are changing. So even people who can't afford, if they are enrolled under kind of insurance scheme and national and state government insurance schemes, now things are fast changing. So the discussion also and the required knowledge on these things also keep changing. Fine. So what kind of pathology is more in this particular bio? CKD MBD, let us discuss all the three components separately. First thing is the bone.
Yes, sir.
So what are the different pathologies that are possible under CKD MBD, that is renal osteodystrophy?
So we usually see it under the turnover, mineralization, and volume classification, TMV classification. So there can be high turnover state or low turnover state. High turnover state, which could be osteitis fibrosa cystica, or low turnover, which is adynamic bone disease. Then in the middle, there is mixed uremic osteodystrophy or osteomalacia can happen, sir. Then mineralization defect, osteomalacia and rickets are both mineralization defects, sir. And then decreased volume can happen, which is with osteoporosis.
Right. So this is a broad classification of TMB, but I'm asking the pathology, exact pathology. If I do a bone biopsy, what are the possible pathologies I would see?
Sir, there could be decreased mineralization and osteocytes or osteoblasts could be less in number. And in him, sir, because there is rickets, so abnormal mineralization of the.
Yeah, there is increased osteoid without unmineralized osteoid, that is osteomalacia and rickets, another one. And then increased bone resorption, increased osteoclastic activity, that is parathormone induced this thing. And the third thing is that osteosclerosis. What is osteosclerosis?
Sir, that is
Is it also possible as part of CKD MBD?
Yes,
and
sir.
where do you see that?
Sir, it is seen in where we are giving excess of excess of
May not be. Actually, osteosclerosis can happen in the collagenous portions of the both ends of the upper and lower plates of the vertebra, where there can be deposition of the minerals and some calcification can happen. So that gives rise to the classical radiological picture known as?
Sir, bone cysts can.
No, Rugger jersey spine. Rugger jersey. What is rugger jersey? Rugger, the rugby players, the ruggers. They wear a jersey where there is alternating the dark and light, black and white bands, if you do the X-ray spine, particularly the lumbar spine, in patients with extreme CKD MBD, you can have this. The upper and lower, the end plates of the vertebra, there will be the deposition of the minerals and some calcification in the collagenous portions over there that will appear as bright. And in between, there will be lucent areas. So this is the classical Ruger jersey spine. So, so let us move on to investigations, and there we'll discuss the radiology part in greater detail. And you said dentition is normal, but you didn't tell me the dental formula in this patient.
Sir, I did not calculate. So I did
Please
not.
do that. Yeah, sometimes, the teeth may appear just normal. But actually the dentition, there'll be delay in dentition and abnormal dentition. Any number of patients we have come across that, and the full complement may not be achieved in some of them at least.
Yes, sir.
So that happens.
Yes, sir.
And the clinical examination, external genitalia, you have this thing, and without forgetting, we have to do a neurological examination, the proximal muscle weakness, number 1. Number 2, looking for the perianal sensation, sphincter tone, all that, not to miss an associated neurogenic component. As I've already said, just because we have picked up one component of CACOD, doesn't mean that story ends over there. Sometimes there can be the clubbing of multiple phenomena, including some neurogenic element.
Yes.
Even though the frank neurogenic bladder, I don't expect, there can be some subtle differences. Subtle involvement can be there, independent of this obstructive pathology, so that we should not miss. So that's it. And then, how did you check the blood pressure?
Sir,
You used appropriate
for the his age, for his size, sir, we used.
that is important, because if you use a very small cuff, that will show a falsely elevated BP. If you use a bigger cuff, that will show a falsely low BP. So, and you said the child is on 2 antihypertensives, so that is important.
Yes.
So, did you look for the cardiac apex, whether there is any cardiac dilatation or cardiac left ventricular hypertrophy kind of thing?
Sir, on examination, I could not appreciate any apex being shifted or LVH, sir.
Right. So let us move on to this thing. Hemoglobin, it's not milligram, it is gram, actually, 7.4 gram. You said peripheral smear showed?
Sir, normocytic normochromic anemia, it was.
Normocytic normochromic. So what does it mean?
Sir, that this is likely anemia of chronic disease, sir, CKD, and not due to any.
It's anemia of chronic disease, entirely different ballgame. Actually, it is due to
CKD.
erythropoietin related. At least you are ruling out iron deficiency. That's what you mean, right?
Yes.
7.4 gram per deciliter. Okay, fine. And then?
Sir, WBC and platelets, WBC were elevated, sir.
So bicarb has not been done, right? So.
Sir, bicarb is 22.3. This is after correction, sir.
After correction. So calcium is 8.7. So what is corrected calcium? Did you correct it?
Sir, for the albumin with this is the corrected calcium, sir.
So how do you correct calcium?
Sir,
with
for
albumin?
Every 1 milligram decrease in
gram.
Every 1 gram decrease in albumin, we have to increase calcium by 0.8, sir.
Yeah. So it is measured serum calcium expressed in milligram per deciliter.
Yes, sir.
Plus 4 minus albumin.
Yes, sir.
4 minus albumin.
Yes, sir.
Into 0.8. Okay. It is ideal to measure ionized calcium.
Yes.
Is it not? Okay, fine. Why? Even, of course, in this patient, its calcium is, it's not that bad. It's 8.7. Even much lower calcium also. Most of the patients, the hypocalcemia is not clinically evident. Why?
Sir, because of the acidosis.
So what is the impact of acidosis on serum calcium?
So acidosis would falsely increase the serum calcium because of the binding of the protein with calcium.
Acidosis increase the ionized component of serum calcium. So that is the more important determinant of your excitability of the cells.
Yes.
So it is not very evident.
Yes.
And in such persons with extremely hypocalcemic patients, if you initiate on, when you initiate on hemodialysis, you have to be extremely careful. Why?
Hypocalcemia will cause seizures. Then,
Because, the rapid correction of acidosis,
yes, sir.
the rapid correction of acidosis, so the ionized calcium level comes down. So suddenly there can be tetany features and even seizures.
Yes.
Okay, so that's it. And what is the impact of acidosis on hemoglobin and oxygen delivery through hemoglobin to the tissues?
Will be more oxygen.
So acidosis causes?
Bohr's effect is there, sir. That
the oxyhemoglobin dissociation curve is shifted to the right.
Yes.
Meaning, despite there being low hemoglobin,
The delivery
is better.
Yes, sir.
So a severely anemic patient, when you initiate hemodialysis, a rapid correction of acidosis. Sometimes, there are many different things happen. So many catastrophes do happen. Is one of the mechanisms is this. Okay, suddenly, and the tissue hypoxia happens because of the rapid correction of alkalosis. That's why, due to multiple reasons, we deliberately keep the dialysis length very short. It is not just dialysis disequilibrium alone. There are so many other factors as well. Okay, phosphorus. Okay. What are the other things?
Sir, as such, X-rays were done.
No, in the blood biochemistry, anything else?
Sir, alkaline phosphatase was
Alkaline phosphatase. What is the importance of alkaline phosphatase in this patient?
Sir, actually, this is total alkaline phosphatase. Of this, majorly, I think bone alkaline phosphatase would be elevated because of the.
Fine. In the absence of facility to measure bone-specific alkaline phosphatase, the total alkaline phosphatase may be a gross surrogate for that.
Yes, sir.
So, if the alkaline phosphatase level is very low,
yes, sir.
What does it mean?
Adynamic.
Adynamic.
Yes, sir.
So, based on alkaline phosphatase, you take a decision of initiating some therapy.
Sir, we can consider giving this cinacalcet.
Cinacalcet will not give at all if there is hypocalcemia.
Hypocalcemia, yes, sir. Phosphate binder.
No, suppose if you plan anti-resorptive therapy,
yes, sir.
After detection of osteoporosis and all that,
yes, sir.
If the alkaline phosphatase is already low,
we will not.
You will not give.
Yes,
you will not give it. Okay, fine. So, what are the lab parameters for CKD MBD? One is serum calcium, that is with albumin corrected calcium, phosphorus, alkaline phosphatase, then
vitamin D.
Vitamin D, 25-hydroxy cholecalciferol.
Yes, sir.
Parathormone.
Yes, sir.
And parathormone. Okay.
Yes, sir.
The KDIGO recommendations of the periodicity or frequency of these lab parameters, CKD MBD parameters.
Yes. In CKD, we started from CKD 2 to 3, sir. There we will be measuring, we should be measuring calcium, phosphorus every 3 months, PTH every 6 months, ALP every 6 months, then every 3 months. Then thereafter in CKD 4 and 5, we should measure calcium, phosphorus monthly, and PTH every 3rd month, alkaline phosphatase monthly, sir. Yes,
yeah,
sir.
I mean, sometimes, we are not able to adhere to the guideline because, parathormone, lack of availability and the cost factor and so on. As the stage advances, the frequency has to be more. In stage 5 CKD, at 1 to 3 months, parathormone has to be done. Okay. So, what do you think will be the parathormone level in this child, in this patient?
Sir, he has a very elevated parathormone levels.
Elevated. Okay. What is the target level of PTH that you have to achieve in patients with stage 4, 5 CKD as per the KDIGO?
Sir, between 2 to 9.
9 times. So,
yes.
how is it expressed, this PTH level?
Picogram per milliliter, sir.
Picogram per liter, milliliter or nanomole per liter?
Yes, sir.
Nanomole per liter. Okay. But are you not surprised and a bit perplexed that you have to achieve a target of up to 2 to 9 times?
Yes, sir.
Why? Why you have to maintain? You can maintain up to 9 times. Does it not sound? Is it not sounding a bit ridiculous?
Sir, actually, the European guidelines, they suggested Much lower actually than this. They suggest only up to 2 to 5 times. This is
Even 5 times is higher.
yes, sir. This is because going down further, we actually have to look at the trends, sir, and not at the exact.
No, we'll come to that later. That is an important point I would like to stress. I'll come to that later. Yeah, you are right. Actually, what Dr. Ankita is trying to stress is that now it's an important advice, important suggestion, or even recommendation. Don't take very drastic decisions of therapy based on just one parameter, be it calcium, be it phosphorus, particularly parathyroid hormone, PTH. Please observe the trend, and based on the trend changes, you take therapeutic decisions. So that is the recent updated guideline, right? Even though it is KDIGO has not been updated. But my question is that why it has to be maintained up to, it can be up to 2 to 9.
So there's a like with mortality and PTH levels when the
I'm not, I mean, it's a different answer.
okay.
Yeah, I mean, somebody has already put in the chat box, and that, there is end organ resistance because of the uremic milieu, because of some uremic toxins, the parathormone, the action at the receptor level is blunted. So to overcome this resistance, the PTH has to be at least 2 times. Otherwise, you'll be pushing to low turnover, kind of low dynamism of the bone. So that risk is there. You're not supposed to just maintain the normal range. Most of the labs, up to 60, 65, 70. That is the most of the labs, 65 picogram per ml. It should be at least 130 because the end organ resistance is there. So it is acceptable if you say that is 2 to 3 times. But why 9 times? It is because there is a lot of intricacies and nuances in measurement of PTH.
Yes.
And what generation PTH measurement we are doing now?
So second and third generation are available. We are usually doing
second generation usually, like, So what exactly you measure? Is an intact parathyroid hormone or?
Sir, we measure between
intact
1 to 74.
84.
Yes, sir.
Yeah, that is called intact PTH. Yes. Intact PTH. But this second generation assays, some of the assays,
yes,
they measure
22.
certain inactive forms of PTH as well.
Yes, sir.
Particularly, like, the oxidized PTH. Oxidized PTH and certain inactive components of PTH also are measured.
Yes, sir.
So they are not biologically active.
Yes.
So this up to 5 times, 6 times, 7 times and all, it can be due to the biologically inactive component. Okay. This is okay. But you tell me, now we know there is a beautiful correlation between the levels of PTH and the well-being of the CKD patient, particularly including mortality, cardiovascular morbidity, mortality, everything.
Yes, sir.
If your argument is that this abnormally hiked PTH is due to biologically inactive PTH, how does it correlate with the poor outcome of the patient?
Uh,
Are you clear about the question?
I understand the question. Sir, even these biologically inactive might be causing some downstream effects.
This oxidized PTH is a surrogate for the oxidative stress of the system. Okay. So if I have more oxidized PTH, it means that I am living with a milieu, an abnormal milieu of heightened oxidative stress. And that oxidative stress definitely contributes for cardiovascular morbidity, mortality, and all-cause mortality. So that way, this is again important. Get the point. But having said that, I am thinking this, I think, the subsequent KDIGO guidelines, things might change because, 9 times is pretty abnormal. And then third generation, the assays are getting ready and a lot of intricacies in that. So it's not easy, PTH, I mean, so many other caveats are there, how to interpret all these things are there. Fine. So it is calcium, corrected calcium, phosphorus, alkaline phosphatase, vitamin D, and PTH. As I've already said in the initial part of my presentation itself, FGF23, it is not to be measured as a routine. It is only for research purpose as well, as of now. What else you do?
Uh,
Of course, you'll do the viral markers and hepatitis B, C, and retrovirus, blood group and type, liver function assessment, all that you'll do. What are the specific tests you do now?
so we will look for vascular calcification.
Exactly. With what X-ray?
So
What is the guideline?
lateral abdominal X-ray we do.
Lateral?
Abdominal lateral X-ray with
Okay.
we will look for calcification in the abdominal aorta from L1 to L4 vertebrae, sir, and we give abdominal aortic.
Do you know the scoring system of this vascular calcification in the lateral abdominal X-ray?
Sir, there is 3 categories, sir: mild, moderate, and severe.
Now it goes after whose name? What name is it?
Sir, it is AAC scoring.
Kaupila.
Okay.
Kaupila. Kauppila. That is lateral abdominal X-ray.
So
And also you can do X-ray of the hand and pelvis to look at the vascular calcification. That's called what scoring it is? Adragao. Okay. So why is this important?
Sir, vascular calcification again is a predictor of
Exactly, cardiovascular morbidity and mortality. I mean, it's an indicator that all is not well. So that is for vascular calcification. Now, quickly tell me the mini skeletal survey to assess the CKD MBD.
So we would do X-ray of sir wrists, sir, and
Fine. In the wrist, what do you see?
sir, widening of the wrists we can see, sir.
Yeah, the widening, the cupping and fraying of the distal radii.
Yes, sir.
The cupping and fraying. Then in the hand,
And sir, the fusion of the epiphysis.
no, subperiosteal resorption. The classical finding due to
sir, again, increased PTH will cause
hyperparathyroidism. Somebody is asking repeating the name of the scoring. The Kaupila for abdominal X-ray and Adragao, ADRAGAO for hand and pelvis scan in the X-ray. Fine. So this is the cupping and fraying. It is the marker of the rickets, and then the subperiosteal resorption, particularly the terminal phalanges. You call it as penciling effect.
Yes, sir.
So that is again due to hyperparathyroidism. Then anything else you see?
Sir, X-ray skull, we can see salt
and pepper. Again, it is an indicator of hyperparathyroidism. There will be areas of lucency because of the osteoclastic resorption of the bone that happens. Then
loser zone can be seen, sir.
Yeah, loser zone. They are otherwise known as pseudo fractures. They appear like fracture lines, but they are actually not true fractures. They are either incomplete fractures or no fracture at all. It's a kind of fracture like impression. Where do you see? In which X-ray?
Sir, in the long bones X-ray.
Actually, the pubic ramus, pubis, and the neck of femur. Actually, what does it represent?
Sir, where the
Again, it represents osteomalacia, the soft bone, where there is a vessel crossing over, the pressure exerted by the vascular pulsation that causes this impression, denting, that appears as loser zone. Okay, anything else? What is brown tumor?
So that is osteotis fibrosa cystica. There are
kind of the conglomerate of the osteoclast, which appear as radiolucent areas.
Yes, sir.
And then I have already said Rugged jersey spine.
Yes, sir.
Rugged jersey spine and the alternating bands of radiolucency, radiodensity. So let me repeat again. It is skull X-ray, X-ray skull, X-ray wrist with hand. And then the X-ray pelvis, the triradiate pelvis. Another description is triradiate pelvis, and then loser zone, and then the spine. So these are the minimum the skeletal survey that you need to do. Okay. Next important question. Will you screen this patient for fracture risk?
Yes, sir. We
Definitely, because he has already sustained a fracture. But we are not sure whether that injury was really forceful injury, appropriate force and causing fracture, and we surmise that it was fragility fracture.
Yes, sir.
Okay. So there has been a change in the guideline from 2009 versus 2017.
Yes, sir.
Initial 2009, they said there is no need for fracture screening, but now it is very clear that you need to screen for fracture risk,
Yes, sir.
at least in those with
Who have
the
had.
presence of other risk factors or those already sustained a fragility fracture.
Yes.
Okay. So what are the risk factors for fracture, increased risk for fracture? CKD specific risk factors, not the general. General is women, postmenopausal, old age. It's all regular, right?
Yes, sir.
Here in CKD,
Sir, adynamic if they have like low.
very good. Adynamic and severe hyperparathyroidism,
Yes, sir.
uremic cachexia,
Yes, sir.
okay, and acidosis
Yes, sir.
and previous fracture. So these are all things. Okay, how do you screen?
So DEXA scan can be done, sir, but in children, it is not the very.
Even in adults in CKD, there are a lot of caveats. That is why initially there are a lot of hesitation, but now they say ideally you are supposed to do to unravel the entire spectrum of the CKD MBD, including osteoporosis, osteopenia, and all that. You are supposed to do bone biopsy, right?
Yes, sir.
But the problem is that, expertise and interpretation, and it is invasive procedure. So it's almost becoming difficult. So we have to resort to the DEXA scan. And if there is osteopenia or osteoporosis, what do you do?
Sir, if there is osteopenia and porosis, we can give sir anti-resorptive treatment.
Before that, so what do you do? How do you correct this hypocalcemia? In
Hypocalcemia.
this gentleman, 8.7. Is it? Are you happy with the 8.7? What is the normal serum calcium level?
Sir, 8.5 to 9.
9 to 10.5. No? Yeah. Okay. Then.
Uh,
So how do you correct this calcium now?
Sir, we can give supplementation. In children, actually, we can even give calcium carbonate supplementation, or we can give calcium-based.
And what is the target phosphorus? Phosphorus is 3.7 here.
Sir, in children, we keep higher targets.
So normal phosphorus for adults, actually, has become an adult, right? Yeah.
Yes, sir.
Fine.
4.5.
Yeah, it is 4.5, around 4.5. So fortunately, there is no hyperphosphatemia here. So if the phosphorus is high, we know that phosphorus should not be high because that is a driver for secondary hyperparathyroidism. And what is the other concern with phosphorus now?
Other concern with phosphorus?
Because phosphorus per se can lead on to vascular calcification. Initially, we thought it is a calcium phosphorus product is a surrogate, but now that concept is gone. This mathematical construct of Ca into P in milligram per deciliter, if it crosses 50, that correlates with vascular calcification, all that is gone. Now we know because what is being deposited in the vessel wall is not calcium phosphate.
It is
actually
hydroxyapatite.
Apatite, yeah. Maybe it was just as a surrogate. It was there, but no need to be attaching too much of significance for that number. And all the more, despite this product not being very high, there are patients with extensive vascular calcification. The explanation is different because the vascular calcification is entirely different ball game. It is not just the calcium phosphorus product. Definitely, it is not there. If you say that, it is kind of trivializing the complexity of the pathophysiology of vascular calcification. Why there is vascular calcification?
So the vascular muscle smooth cells, they de-differentiate into osteocyte-like cells and
osteoblast-like cells. So the phosphorus per se can cause this.
Yes, sir.
The phosphorus per se. Phosphorus is vasculotoxic. Again, there is a beautiful NEJM article published a few years ago. With a pictorial representation and so on. Phosphorus per se is vasculotoxic, and that can transform the vascular smooth muscle cells into osteoblast-like cells, and osteoblast has got a tendency to trap calcium that can result in that. Number one. Number two, what happens to the endogenous inhibitors of vascular calcification?
Between A, magnesium pyrophosphate, all of
and matrix G1A protein.
GLA protein, yes.
And these are the endogenous inhibitors.
Yes, sir.
So the more importantly, fetubin A. Yes, so what happens to these levels in CKD?
So uremic value will decrease fetubin
A. So there is vascular calcification chances are increased. So, okay. So phosphorus within normal range. The target is normal range and calcium normal range. And the parathormone, we have already said. And when there is vitamin D deficiency, that has to be corrected. Okay, fine. Then the phosphorus is high. How do you manage?
So we can give phosphate. We have to look at the dietary phosphate intake, sir.
Right.
So plant sources are the bioavailability is low, but animal sources and food additives have a very high biological availability, and so that has to be made sure that it is not there. Then we can add
Particularly the beverages and additives,
yes,
they
sir.
should not be taken. So that's very important. And we have to resort to the help of the dietary therapist
Yes, sir.
and the dietary restriction, and then phosphate binders.
Yes.
So in whom will you prefer a non-calcium based phosphate binders?
Sir, in somebody like adults and somebody with the higher calcium levels, we should
Yeah, when
prefer.
the calcium level is already high, pretty high.
Yes, sir.
So the calcium overload,
Yes, sir.
that would be a favorable factor for vascular calcification that has to be avoided. Number one. Number two, very high calcium levels will cause suppression of the parathormone.
Yes, sir.
So that also is another problem.
And
So
adynamic.
you have to resort to this thing. So what are the non-calcium based phosphate binders?
Sir, Sevel-MR, lanthanum carbon.
Lanthanum. Any other phosphate binders you know of?
That ferric, sucroferric oxyhydride.
And one more.
Ferric citrate.
One more, and from Madurai, Dr. Sampath Kumar did a lot of work and published on this. Niacin. Yeah, niacin. Of course, the side effects are some flushing and other things, but that really helps, right? Niacin. So the phosphorus management sometimes becomes very difficult. Okay, not easy. And a patient who's on dialysis, you can intensify the dialysis. The delivered dose of dialysis can be increased, right?
Yes.
Roughly about, a person who undergoes a 4-hour session and 3 sessions per week, about 2 to 2.5 gram of phosphorus is removed during hemodialysis.
Yes, sir.
And so accordingly, the intake has to be adjusted in such a way.
Yes.
So at any cost, hyperphosphatemia has to be averted. So what are the indications for calcitriol?
Sir, low serum vitamin D levels is one, sir.
No. Calcitriol is different in vitamin D level. Vitamin D is 25-hydroxycholecalciferol. If that is deficient, that you will be giving.
Yes, sir. Even after the adequate phosphate restriction and binders, if PTH continues to be high, then it has to.
Exactly.
The
And a point that is being stressed in the literature now, in the recent literature, is that the calcitriol is overused and abused in early stages of CKD. Actually, there is no place for calcitriol in most of the patients with early stages of CKD.
Yes.
You have to start thinking about calcitriol prescription only in stage 4 and beyond,
Yes.
particularly dialysis patients and so on. Why this caution?
Sir, that FGF23 levels are increased by vitamin D because of it will cause there are vitamin D receptors in the osteocytes and blasts where the FGF is produced.
Not just that, that can cause suppression of parathormone again.
Yes,
that can push to a dynamism, not just your calcium, but also very high doses of calcitriol also can do that effect.
Yes.
Okay, that can lead on to hypercalcemia. Not just that, calcitriol directly suppresses parathormone, right?
Yes.
So there should be a true indication for that. And even after starting that, you have to be closely monitoring. So the side effects of calcitriol is hypercalcemia.
Yes.
Okay, so in that tricky situation, how do you proceed?
Sir, we can add calcium mimetics, sir.
Yeah, vitamin D analogs like paricalcitol and so on.
Yes.
Paricalcitol. What is calcium mimetic?
Sir, they will enhance the sensitivity of calcium sensing receptor to calcium through the extracellular calcium. So
molecule is cinacalcet.
Cinacalcet and
So what is the problem with cinacalcet? It is not an easy drug. There are a lot of side effects.
Hypocalcemia risk is high.
IgA side effects and hypocalcemia. So you have to be extremely careful while prescribing cinacalcet. And before that, we can attempt vitamin D analogs like doxorcalciferol or paricalcitol. So vitamin D analogs, how does it differ from calcitriol? It mediates the same action, causes suppression of parathormone, but without causing hypercalcemic effect.
Yes.
Little selective in causing suppression of PTH.
Yes.
So that is the advantage of it. And there are some named trials with paricalcitol and all that. Please learn about that as well. So this is about hyperphosphatemia and then hyperparathyroidism and vitamin D correction. And what else? Yeah, growth retardation. And how do you correct acidosis?
Sir, soda bicarb we can give, sir.
The target bicarb is?
So more than 22 at least, sir. And in
Yeah.
children, higher the better. So we can even go up to 28 or 30, sir.
Okay, fine. So what is the worst and life-threatening complication of CKD MBD?
Sir, vascular calcifications and
Vascular calcification?
calciphylaxis, sir.
Yeah. So what is the current terminology for calciphylaxis?
Calcific uremic, calcific uremic arteriopathy.
Arteriolopathy. So why is it devastating disease entity?
Sir, it will cause tissue hypoxia.
Yeah, exactly. So what happens is that, it is not just the calcification of the dermal vessels. It is also there is a microcalcification of the microvasculature of the adipose tissue and the skin. It leads on to kind of a necrosis and a lot of inflammation and the limb threatening and ultimately life threatening and so on. The pathophysiology is very complex. It doesn't mean that it has to happen only in patients with hyperparathyroidism. There are instances where without very severe hyperparathyroidism also it has been noted. Now we know actually it is very complex in the sense that so many contributory factors have been described as contributing for causing this calciphylaxis, like vitamin D receptor polymorphism and aberrance in the adipocyte pro-inflammatory cytokine milieu. And another investigator says that, when the people with recurrent endothelial injury, they are vulnerable for calciphylaxis. And there are some papers which have demonstrated hypercoagulable state, like protein CS and deficiency and so on. And also greater reduction of the endogenous inhibitors of vascular calcification like Phetuin A. All these. So it is a very complex entity. It doesn't mean that, it happens only in people with extreme degree of hyperparathyroidism. Of course, extreme degree of hyperparathyroidism, definitely the risk is there, but it doesn't mean that it has to be there. So it is very complex. And what is the drug of choice for this?
Sodium thiosulfate.
Yeah, right.
Hyperbaric oxygen.
And another compound, a recent compound is SNF 472. And of course, there is possibly there is a role for vitamin K, no?
Because of matrix.
Because these inhibitors of the vascular calcification are vitamin K dependent. Matrix G1A and Phetuin, they're all vitamin K dependent factors. So that is, we will not like to see a patient with calcific uremic arteriolopathy because it has got very poor prognosis. But some authors, they have published a very optimistic note saying that, early detection, identification, and then appropriate administration of thiosulfate in the right dose, they have demonstrated some resolution of the pathology and so on. So what happened to this child? A poor child, he does not have suitable vessels for creation of AV fistula. How are you going to plan his RRT?
Sir, actually, PD would be a good option for him, sir. And then after that, we can go for, like, if the bladder is corrected, we can go for transplant. But finances are poor, so.
Finances, but now there is
Yes,
Prime
sir.
Minister's
Yes, sir.
insurance program is there, and I think things will change in the right direction in the future. Already in Tamil Nadu, it is there actually. The vibrant program is there, and cost is not a factor. And even post-transplant immunosuppression, lifelong also is free.
Yes.
But before that, so many things have to be done. Will you advocate a bladder assessment by urodynamic study in him?
Sir, after this like infection part is
Fine.
resolved, we can go for urodynamics.
So that is very important, if you want to go plan for a transplant. Definitely his transplant is ideal for him because he is so young.
Yes.
A lot of other things are there and he may not do well on a long term in any form of dialysis. So definitely transplant. For that, there are so many things that have to be done. First is bladder assessment and what exactly is the type of bladder and categorizing it and then trying to address the issue. And you said it's a small bladder, whether he requires any augmentation.
Yes, sir.
And all those things. So that is number one, and treatment of infection, correction of anemia and correction of hypocalcemia.
Yes.
Nutrition, consideration of growth growth hormone therapy, after addressing all these issues, still the growth velocity is not improving over a period of 6 months to 1 year, still that option is there.
Yes, sir.
And then planning for transplant, correction of acidosis and appropriate dialysis. And what is the special problem you anticipate in CAPD with relevance to CKD MBD?
Sir, adynamic bone disease is
More common. So more adynamic bone disease. So what are the clinical characteristics of adynamic bone disease? Clinical.
Clinically, sir, they are more prone to fractures, much more prone to
fracture, and bone pain is more in them.
Yes, sir.
Bone pain can be there in any form of ROD,
Yes.
but bone pain is more. And third thing, and laboratory abnormality?
So PTH would be low, ALP would be low, and
calcium, hypercalcemia is there in most of them.
Calcium would be high, phosphate may be low, sir.
Yeah, calcium is more in most of them, and vulnerability for fracture is more. And this adynamic bone disease incidence and the prevalence is increasing vis-a-vis osteomalacia. So across the globe now. So we need to know more about this thing.
Yes.
I think we have discussed almost all these things, and the greatest worry is that there is no social support for this unfortunate patient, because he has lost his father. Yes. And a single parent taking him to a hospital again and again for investigations and treatment. So I 100% I agree that CAPD should be the right choice for him, and CAPD also is very much covered under insurance scheme. Please explore the possibility of trying this thing.
Yes.
And PTH has not been done, right, in him?
PTH was high, sir. PTH was 808 for him, sir.
I didn't see that.
Yes, sir. So PTH is high, sir.
800. Oh, yeah, it is. Yeah, 800. So, are you happy with that? And
sir, this is higher than the ninth.
So we have to try to correct the hypocalcemia and see the trend, and then think of calcitriol.
Yes, sir.
Definitely is a candidate for calcitriol to cause suppression of that.
Yes.
So what are the indications for parathyroidectomy?
Sir, even after giving calcitriol and calcimimetic agents, if the PTH is consistently high, and otherwise there is even hyperparathyroidism causing anemia or
not amenable to medical management. That is addressing the hypocalcemia, hyperphosphatemia, and calcitriol therapy. Number 1. Number 2.
Sir, if there is any adenoma,
detection and intractable pruritus.
Pruritus, yes,
intractable pruritus, and then detection of a nodule, meaning it is no longer secondary hyperparathyroidism. It has become a tertiary hyperparathyroidism.
Yes, sir.
Secondary hyperparathyroidism meaning still it will be amenable to correction of hypocalcemia and hyperphosphatemia, but tertiary meaning it has become a kind of an autonomous nodule. So that will keep on pouring out a lot of PTH, and that is an indication for this thing. And again, there are 2 types of parathyroidectomy. They are
sir, total
subtotal parathyroidectomy, and then total parathyroidectomy with the implantation in the small portion of it in the subdermally.
Yes.
So this thing is that. What is an important complication of parathyroidectomy?
Sir, that hypocalcemia which happens after.
Yeah, you are right. You are right.
Bone.
You are hungry.
Hungry bone. Hungry.
Yeah, it's 10 o'clock now. Yeah, good. Hungry bone syndrome. Like hypocalcemia, it can be an emergency. It has to be looked for and treated.
Yes.
That is there. And somebody has asked a growth hormone indication post-transplant. Yes, there is an indication, but you have to wait until 1 year. Even after 1 year, with good graft function, with good correction of acidosis and normalization of the graft function, if the growth velocity is not on the positive side, and if the growth potential is still there, and if you are not able to switch over to steroid sparing regimen.
Yes.
So, because even though the renal failure is corrected and kidney function is restored, that will be an driver for growth, but the steroid will cause a premature closure of the epiphysis and so on. So some of them go and switch over to steroid if that is not possible, steroid-free regimen or steroid avoidance regimen not possible. And even after 1 year of adequate engraftment, growth is not progressing, there is an indication for this.
Yes.
Okay. I think, still there are so many things to be covered, but already it's late and people are also leaving. And you have presented so well.
Thank you, sir.
More than 90% of the questions you just answered, and you seem to be well read. And just concentrate on the areas where some more need to be. And the CKD MBD, still there are so many questions remain rather than answers. And for instance, the bisphosphonates, if you detect DEXA scan and if you detect osteoporosis, you're supposed to give bisphosphonates. This patient, it has to be given because he already has suffered a fracture. If you do a DEXA and if it shows, severe osteopenia versus osteoporosis, you have to give it.
Yes.
But there are a lot of controversies. There is a statement saying that, bisphosphonates should not be contemplated if eGFR is less than 30, 35. But then how will you give for it? So it was all previous. Now the consensus in the KDIGO guidelines is that it's not consensus, it's a kind of a suggestion or an advice saying that you individualize the patient, look at the trend, and then assess all the factors and then go ahead. Just because somebody is in CKD stage 5D, it is not a deterrent for bisphosphonate therapy. But you choose the right drug. You can't say that, bisphosphonate cannot be given if the GFR is less than 30. Still you can give. But in the past, bisphosphonates, there are a lot of side effects, and you have to resort to the alendronate, and we just got a lot of side effects like GI side effects, and so difficult to take and all that. And pamidronate, it causes problems and it requires dose modification. But now we have denosumab, more and more of reports of the positive benefits of denosumab. Initially, people used to be worried about denosumab's rare side effects like osteonecrosis of the jaw and atypical femoral fractures, and of course the cost. But now more and more reports are reassuring reports. On the other hand, think of the other way. If this boy happens to have another fracture, who will take care of him? That will be the beginning of his end. So we have to gauge the benefit and the risk, and then you have to go ahead. Now, denosumab has really changed the scenario of anti-resorptive, osteoporosis management in CKD that way. Anyhow, thank you so much. And the discussion is not complete at all. I need at least another 1 hour, at least another half an hour. Some issues are there, but anyhow, we'll catch up with that. And thank you so much. And it was a nice presentation. I profusely thank Dr. Vineet and Dr. Jasmine for helping to run this program. And I thank all the attendees and wish you all a wonderful year ahead. Thank you so much.
Thank you, sir. You have already answered almost all the questions that were present in the chat box. Maybe we can take one extra question, that was why antibiotic has no role in secondary VUR and it is only recommended in primary VUR. This someone has asked, sir.
Yeah, actually that is the guideline because the secondary VUR meaning there is no primary problem. Actually, primary VUR is the congenital shortening of the terminal portion of the ureter. That is a submucosal intramural. So that abnormality always remains and that VUR will continue. A secondary VUR, if you correct the cause for VUR, the VUR is supposed to get corrected. For instance, something causing obstruction, because of that stagnation and increased intravesical pressure, and that causes VUR. If you correct that obstruction, VUR is going to subside. So that same vulnerability for infection is not there. So that is the simple common sense. But I would like to individualize. In this patient, actually, he has suffered repeated episodes of UTI. Definitely, I would have gone for antibiotics. And at least I would have gone to a greater extent of investigating him as to what is causing recurrent UTI in him, whether it was an insufficient fulguration or inherent bladder pathology, voiding dysfunction that was causing stagnation of urine and causing UTI and so on. But as a rule, secondary VUR, it is not, the routine antibiotic prophylaxis is not advocated.
Yes, sir. And there is another interesting question, like how do we calculate the dose of soda mint or sodium bicarbonate that has to be prescribed in these children with CKD?
No, as per the guidelines, start with the starting dose and then periodically monitor the bicarb, and until you reach the target of at least 22, you escalate the dose. So each person will require different kind of dosing.
Okay, sir. And sir,
Particularly a CKD of same severity due to, yeah, please go ahead.
okay, sir. And lastly, you said that bisphosphonates have many side effects. So, do you use teriparatide in these patients? Like someone has asked, like when do you give teriparatide? And
Teriparatide, you give it in adynamic, low turnover disease. Low turnover disease. It's like when there is hypoparathyroidism, it's like it mediates the same action like parathormone. It boosts the activity of the osteoblast and osteoclast. So it is indicated in low turnover disease, not in hyperparathyroidism. In hyperparathyroidism, you have to give calcitriol. If hypercalcemia is the stumbling block over there, you have to go for paricalcitrol, vitamin D analog. The teriparatide is for low turnover. And it is not anti-resorptive. Anti-resorptive therapy is bisphonates or denosumab.
okay,
The
sir.
bisphonates common practice in common use are one is zoledronate and then pamidronate, then alendronate and risidronate. So many things are there. The alendronate is oral, pamidronate is IV infusion, and zoledronate is again IV. Now, denosumab is a different mechanism of action. It's not exactly bisphosphonate. It is a rank ligand antagonist, and it inhibits the osteoclastic activity. It is given subcutaneously. It is a bit expensive. That is a factor.
Due to the paucity of time, we may not be able to take any further questions.
Ionized calcium is done in the laboratories. There are some laboratories, they specifically mention they measure ionized calcium. We need not calculate, it is measured.
Image.
Thank you, sir, and thank you everyone for attending our session. It was a very educative session and we learned a lot, sir. Thank you everyone, and we can now depart. And
Good night. Thank you so much.
Thank you, everyone. Good night.
Thank you. Bye-bye.